Now, in this class, we are going to into the detail of the diuretics. Diuretics basically they are classified into four classes. First, high ceiling diuretics. Second, medium efficacy diuretics. Third, weak or adjuvant diuretics, and fourth, potassium sparing diuretics. High ceiling diuretics they are furosemide, bumetanide, and toracimide. Medium efficacy diuretics they are divided into two: benzothiazide and thiazide like. Benzothiazide includes hydrochlorothiazide, hydroflumethiazide, and benzthiazide. And thiazide-like includes chlorthalidone, metalazone, zypomide, indopamide, and lipomide. Weak or adjuvant diuretics, it includes two types: carbonic anhydrase inhibitor and osmotic diuretics. Carbonic anhydrase inhibitor is its example acetazolamide, and osmotic diuretics are mannitol, glycerol, and isosorbide. Potassium sparing diuretics they are of two types. First, aldosterone antagonist, and second, renal epithelial sodium channel inhibitors. Aldosterone antagonist it is of there are two drugs, spironolactone and eplerenone. Example of renal epithelial sodium channel inhibitors are amiloride and triamterene. Now we will go into the detail about this diuretics. First, high ceiling diuretics. High ceiling diuretics these are the drugs that acts very acts in the thick ascending limb loop of Henle. The basic mechanism of action of these high ceiling diuretics is nothing but they act by inhibiting the thick ascending limb loop of Henle. So how they act? They inhibit in the thick ascending limb loop of Henle. We know that which pump operates there? Sodium potassium 2 chloride pump. So this drug inhibits the sodium potassium 2 chloride pump. Now we will see what happens if the sodium potassium 2 chloride pump is inhibited. We had already learned about the relevant physiology of urine formation. Now we know that high ceiling diuretics acts by inhibiting this pump, sodium potassium 2 chloride pump. So what happens that due to this the sodium will not be reabsorbed. So that's a potassium also it will be not absorbed. Also the 2 chloride will be not reabsorbed. So what will be the consequences of this? This as sodium will not be absorbed. Due to this, potassium if influx from the interstitium into the tubular cell will be blocked. Due to this, the tubular cell concentration of potassium will be reduced. Therefore, less efflux of potassium from the tubular cell into the lumen. So what happens due to this? The electrochemical gradient, positive electrochemical gradient generated into the tubular lumen reduces. As a result of this, calcium and magnesium excretion will be affected. Hence, high ceiling diuretics causes calcium as well as magnesium excretion because the lumen in the electropositive potential difference is abolished. Also, here the potassium excretion will be also increased. How it will be increased? Because this pump is responsible for not only for the absorption of sodium, it is also responsible for the absorption of potassium. That's why the potassium excretion is also increases. Basically, high ceiling diuretics acts by binding with the this site. Chloride binding site present on sodium potassium 2 chloride pump is the binding site for the high ceiling diuretics. Now we go in detail about the examples. First, furosemide. Furosemide, its action is prompt and its major site of action is thick ascending limb loop of Henle. It basically inhibits sodium potassium 2 chloride co-transport. So how it acts? It is secreted into the proximal tubule by organic anion transport, and then it reaches its site of action, that is thick ascending limb loop of Henle. And from where it acts from the luminal side of the membrane. So due to this, K plus excretion is also increased due to the high sodium load reaching the distal tubule. Hence this is called as potassium wasting diuretics. Furosemide also has weak carbonic anhydrase inhibitory action. Carbonic anhydrase is responsible for absorption of water and CO2 from the tubular lumen into the tubular cell. Here we had already seen that due to the carbonic anhydrase inhibitory action, this step will be affected. Due to this, also for the fusion as well as splitting, the carbonic anhydrase is required. Hence, HCO3 minus excretion is also increased. Another most important point about the furosemide it is that it itself some compensatory mechanism. What is what it sets compensatory mechanism? These compensatory mechanism are responsible for the limitations to its own diuretic action. So how this compensatory mechanism works? We all know the furosemide is promoting the sodium excretion. Due to this, there is the reduced entry of sodium into the macula densa. Due to this, which causes the renin release, and this renin angiotensin aldosterone system is one of the most major compensatory mechanism that limits the diuretic action of furosemide. Also, we all know that furosemide is inhibiting the lumen electropositive potential difference. Due to this, the calcium as well as magnesium excretion will be promoted. Also, furosemide increases the blood uric acid level by competing with its secretion into the proximal tubule and increasing its reabsorption in the proximal tubule. Now, second drug is bumetanide. Bumetanide is more potent than furosemide, highly effective in pulmonary edema, and rest properties are similar to furosemide. And then toracemide. Toracemide, most properties are similar to furosemide and 2 to 3 times more potent. Now, we will go into detail about the furosemide. So, there is no extra need to mug up the uses of the furosemide. We can just learn the uses of furosemide on based on his mechanism of action. We all know. First, furosemide, what is the drug? It is the diuretic. Diuretics means it promotes sodium as well as water excretion. So what will be the use in what will be the therapeutic use? It will be helpful in the treatment of edema. All the high ceiling diuretics are used in the treatment of edema, irrespective of their etiology. Also, the where which type of edema, cerebral edema, acute pulmonary edema, they can be used. Now, as water and sodium electrolyte excretion is promoting, so this will also reduce the extracellular fluid volume. This reduced extracellular fluid volume also causes the reduction in the blood volume. Due to the reduction in the blood volume, the venous rhythm to the right atrium reduces. As a result of this, end diastolic volume reduces, and this will also helps in the reduction in the blood pressure. So what will be the fourth is high saline diuretics. They can be used in the treatment of hypertension. But one point important here to note that high saline diuretics are indicated in hypertension only in the presence of renal insufficiency. Whenever there is a renal insufficiency, then and then only high saline diuretics are used. Now, here, here we can see that high saline diuretics are used in the treatment of edema, irrespective of their etiology. And high saline diuretics are most preferentially preferred in chronic heart failure for the rapid mobilization of edema, because how why they are using in the treatment of edema, they are causing the excretion of sodium as well as water. And next, acute pulmonary edema, cerebral edema, hypertension. How hypertension they are benefiting? Because as they promoting the sodium as well as water excretion, therefore the extracellular fluid volume reduces. Whenever the extracellular fluid volume reduces, venous return to the right atrium reduces. Also, due to this, the blood pressure will be reduced. Also, the furosemide may be infused along with the blood transfusion to prevent volume overload. Furosemide can be given along during the process of blood transfusion to prevent volume overload. Also, it can be used to treat hypercalcemia of malignancy. We all know that high ceiling diuretics are causing the abolition of the lumen electropositive potential difference. Due to this, the calcium as well as magnesium excretion are inhibited, and hence their excretion is promoted. Therefore, furosemide or high ceiling diuretics can be used in the treatment of hypercalcemia of malignancy.